Thank you. I know this is the last session of the day. Hopefully, I'll keep you entertained. So I'm going to tell you a story of an issue that is very close to my heart and a passion, really. So when Rahul suggested about 18 months ago, I think we wrote this bid. So I'm glad that it worked, and it's great to see many of you here. Hopefully, 2 weeks, I've already learned a lot in the day, and hopefully you'll also learn something out of it. When it comes to machine learning, and I know there's quite a lot happens in acute care, and there's a lot happened on image analysis. So there is a bias towards supporting expertise, clinicians, etc. However, I think, still do need to do a lot on predicting non-communicable diseases. Why NCDs and cardiovascular disease is the single biggest cause of death, even in many parts of Africa where infection still rife, but apart from 7 or 8 countries, cardiovascular disease has taken over as the leading cause of death. Cancer comes also quite close to the top. So my talk, the title, I'm not going to show you any machine learning data. We have done some small scale machine learning in this field, but I'm not going to show you any of that today. So gestational diabetes, or diabetes in pregnancies, is a clinical field that I'm associated with. And I also do research on this area for the last 15 years or so. So my title is Diabetes in Pregnancy. Is that a cause of the obesity and diabetes and cardiovascular disease epidemic we see, not just within India, but across many parts of the world? So I work in University of Warwick, which is right in the middle of England, about 90 miles, 1.5 hours from north and west of London. It's a nice campus, not as good as this one, and it has a beautiful castle next to it. If any of you are visiting, you must certainly do that. So the first half an hour or so, I'm going to tell you a story, trying to get our head together. I know you're all thinking and the various technologies of machine learning and AI, etc. So I'm going to take you back to use some common sense approach for this problem. So I'll talk briefly on what gestational diabetes is, what is it, and why is it important for the mother as well as the child, and why simple analysis cannot solve the unresolved questions. Diabetes is one of the areas where a huge amount of money goes into it, because it's increasingly common as we are eating too much, as we are getting live longer, etc. But gestational diabetes, still huge amount of work needs to be done because it is complex, as 2 lives involved. So I'll hopefully will give you some overview of why I think personally that some innovative methodologies are needed to solve some of these questions. Right, just to ensure that we're all awake. So this is 5 mammalian species. And I'm going to ask you guys to rank according to the percentage of body fat of these 5 species. Obviously, you can see the humans, brown bear, elephant seal, harp seal, and pigs. So who charts the list of these, do you think, in terms of percentage of body fat we have at the time of birth, or these 5 species? Sorry, at the time of birth. Not us, not at this age. I know I should have put a baby's picture, but I purposefully put that picture. Any ideas? Bear, brown bear? Elephant seal? Humans? Okay. Any? Okay. Okay. Right. It is us, I'm afraid. So as I said, this is at the time of birth. So evolutionarily, we are designed to store energy in the form of fat. We know fat is bad, especially for as we get older, and it causes lots of issues in terms of diabetes, complications, as well as cardiovascular disease. So if you actually look at it, this is the data. It's not new data. This is good 30 years old. But look at that. We were, you know, we are way ahead compared to many of the mammalian species. That's important to remember in this context. Of course, if I used this picture, you would have all guessed who tops the list. This is a picture taken for a baby born in Pune, in one of my colleagues' collaborators' unit, and this is a baby born in Southampton, southern part of England. These babies are not born to mothers with diabetes. These are born to mothers who have normal pregnancy. So you could see you don't really need any complex measurements or MRI scans to calculate the amount of fat, especially around the belly. By the way, if you have fat around the belly, which some of you notice as we get older, we accumulate it in the middle, is bad for cardiovascular disease and many other conditions. And if you have a fat in our bum area and thighs, that is actually protective for cardiovascular disease. So you could see without any measurements that this baby, despite overall she's being small, that you could see it already has a higher fat content. Hold that thought, I'll come back to this. So we don't really need a rocket scientist to then tell us the problem has to start before that, if this is obvious at the time of birth. Right. So I'll come back to that in a second. So in terms of gestational diabetes, what is it? It is essentially hyperglycemia, or high glucose levels gets detected first time in pregnancy. Pregnancy is a state where there's multiple hormones are produced to keep the baby alive, and then for lots of other reasons. All of that are designed to raise our blood glucose levels. So, but when it crosses a certain point, that's when it becomes an issue. So why do we need to worry about this condition? So what? So yes, if this is nature's process, somebody goes over a certain limit, do we need to really worry about it? This is the data, not all of it is published, but this is data from our studies. Traditional thought is the gestational diabetes affects about 5% of all pregnant women. That was about 20 years ago. Now, 30 years ago, now we're talking about 10 to 15% of all pregnant women. So if you go and test for diabetes, 1 in 6 women are supposed to have diabetes. That itself is an alarming number. But these are a series of studies we have set up. A PRIDE study was set up in the UK now almost 10 years ago. We don't test every pregnant woman in the UK. We roughly measure about 40 to 50%. And even with that, there is anywhere between 12 and 18%, depending on which ethnic group you're looking at. With Dr. Ram in the audience and Dr. Suresh, we set the study in India, in Chennai, Hyderabad, and Pondicherry. It's very worrying. It's nearly 40% based on the current criteria that is being used to define. Whereas if you look at Kenya, And this was set up in a site where it's high altitude, where marathon runners go for training. So it's a different geography, but it's only 3% of all pregnant women. And we've just completed a study in Malaysia and Thailand, and depends on which criteria you look at. There are anywhere between 20 and 40%. So these are big numbers. These are very, very worrying numbers, let alone the complications of it. Just dealing with the volume of these kind of numbers and managing them in pregnancy, you can imagine how big an issue it is for any healthcare system in the world. And these are, I'll show a couple of slides in showing how there is a temporal increase in the rates of GDM. This is data from US, and in space of 14 years, it doubled, and this data is old, nearly 20 years old, and the numbers are continuing to increase. Even one of the healthiest nations in Northern European countries like Sweden, there's a 64% relative increase in space of 10 years. So the burden is not only high, it is also rapidly increasing. Hence, we do need to worry about gestational diabetes, because for an obstetrician, this is one of the common medical problems they have to deal with, whichever part of the world you go to. And worryingly, 90% of this burden happens in low and middle income countries. So which causes another problem. How do you actually train people, manage people, monitor people? And the resources are difficult even in developed countries, let alone in low and middle income countries. So just to as a simple way of thinking, this is gestation. Anyway, and 85% of gestational diabetes goes back to, disappears soon after birth, which is great, which is fantastic. But at the same time, that also causes another problem, because these women are not forgotten once she's delivered, and the glucose levels drops, and then everybody says, oh, the problem has gone away. However, it doesn't go away, and you need to think that this is a pre-diabetes state. So I usually tell my patients that think that nature has given you a window of opportunity, what lies ahead, 10 years, 20 years. We don't need any complex modeling to identify that, but we know that for sure. So in terms of quantifying what is your risk of diabetes and diabetes-related problem, this is one example of our study from the UK. And there's 4 panels here. This is, we studied about 9,000 mothers with diabetes with 4 times the control group. This is the primary care database that we have access to in the UK across the country. It covers about 10, 11 million population. And look at the rate of increase in diabetes. So this is mothers, a woman who had a history of diabetes in pregnancy compared to those who didn't. And you could see it's very, very rapidly. So this is years in terms of time in x-axis. So you could see. So the incident diabetes rate in this study, we showed nearly 22-fold compared to women who didn't have diabetes. I think this is an overestimate, but the general estimate is about 10 to 13 times. If you belong to a certain ethnic group, so that's even higher. What surprised us was this panel here this is the documented heart disease, or ischemic heart disease, or coronary artery disease. And you could see by 10 years of the index pregnancy, the rate of ischemic heart disease was going up. We are talking about women in their mid, possibly late 40s. We are talking about pre-menopausal women. Women's cardiovascular disease risk goes up after they go through the menopause, but we are talking about this is pre-menopausal women, and the risk of diabetes is, in our study, showed more than twice. We didn't see huge evidence of stroke increase, but I think that is to do with the age. But we also saw doubling of the hypertension, which is also an important risk factor for people developing heart disease. So these are real risks. I'll skip this slide in the interest of time. So what happens to the baby? So what happens to the offspring? So if you imagine a simple rule, glucose is an important fuel for our growth, along with fat and amino acids. So if you have excess glucose, it goes through the placenta, the baby gets the excess glucose. Like us, if you overeat and if you don't use it, the baby is going to store it, and it stores in the form of fat. Remember the baby picture? So that starts well before we are all born. So by the way, it's damage limitation for us. So once we reach adulthood, we can't abolish that risk. This is a damage limitation for all of us. It's not doom and gloom. We can still prevent diabetes and heart disease, but that perpetuates into the next generation. There is evidence that it also has an effect on our DNA, what we call epigenetic effect, which then potentially transmits to multiple generations. There are animal studies shows that if there is an insult, when you are inside your mother's tummy, that insult may go beyond the immediate generation. In fact, one of animal studies showed it may last for many, many generations, and that study reported as 50 generations. So there's no hope for us, but there is potentially modifiable features. So if the baby then gets child and adolescent obesity and much higher risk of cardiovascular disease, and then if it happens to be a girl, she may be higher risk of diabetes, and this cycle goes on. So this is the two babies who are born to mothers in my unit with gestational diabetes. And I just told you that if the baby gets excess glucose, you get extra fat. But we also see babies who are too small. Again, we cannot explain this. And this happens even in mothers without diabetes, but extreme obesity. So mother's body weight and glucose are the two biggest driver of baby's size at birth. But what we can't explain is why some mothers have small babies. So again, the process is complex and our understanding is still very limited, even though there's a huge amount of work goes on in this area. So, okay, we see that at birth. Does that translate into risk in adulthood? You know, or had probably ate too much this lunchtime, so our current lifestyle changes. We are all using smartphone few minutes before we go to bed. Our sleep is affected, our stress level has gone up significantly, so that all of those lifestyle factors surely must be contributing to the risk. So does it actually matter what is your risk at birth? Can we actually change it? Yes, we can change it. Yes, the current lifestyle and diet matters, but if you are programmed to deal with it, certain risk and risk factors in certain way, we may have two different trajectory. Many of you will have friends who will eat more than what we eat, but remains thin, and we eat too much, and we can get, I'm sure all of you will have examples of friends like that. So that's the programming. So that's from birth or possibly well before birth. So what this slide shows is, and this is again data from Scandinavia, this is the background population. What it shows is they asked the question, is it to do with the glucose alone? Is it to do with something else? So what they did is they followed two models. One, mothers with diabetes, developed diabetes in pregnancy or gestational diabetes. The other group of mothers who had type 1 diabetes. So type 1 diabetes usually happens in the young with high glucose. So whereas gestational diabetes is like diabetes, is a multi-genetic issue. So they asked the question, is it to do with the glucose? Is it to do with something else? So what they showed is So this and this column here is babies born to mothers with type 1 diabetes. They followed up this cohort right up to 21 years of age. And this is the group who had family history of diabetes, meaning some genetic risk, but the mother or woman didn't develop diabetes in pregnancy. So these children's mother didn't develop diabetes in pregnancy, whereas this group of kids who not only had family history of diabetes, but their mother also had diabetes in pregnancy. So you could see these are odds ratios. These are not fold risk, but compared to the background population, look, these are 4 to 8. These are not small odds ratios to ignore. So there is a clear evidence that it not only affects the mother, but it also affects the children. And this is a recent study, not by our group, also showed that it's still small numbers when it comes to 30 and 40 years of age. You can see you need lifelong studies to really understand the complexity of this. But what this shows is the blue line here is those who are exposed to kids who are exposed to diabetes when they are during pregnancy, and the dotted line are unexposed. And this is years of age, and this is the risk of cardiovascular disease. What it shows is it's clearly the cardiovascular disease risk is high, but it is also happening earlier. Again, you would have heard several stories of friends, relatives who have getting heart attack at the age of 25, 30. So this is happening in young. And I would say these are all adverse programming well before. I'm not saying this is purely due to diabetes in pregnancy, but other adverse programming. Obviously, this is my interest, hence I study this. So in summary, so why do we need to worry about GDM? So this is a huge burden for any healthcare system to deal with. We're still not sure how to risk stratify and predict who is going to develop complications and then just target them. But these are not just metabolic risk. I mean, most of them highlighted here as metabolic risk. Some of you may have heard of the rapidly increasing burden of non-alcoholic fatty liver disease. So this is a fat accumulation in the liver, like what we accumulate fat in the middle. But worryingly, we are seeing there's a couple of studies we recently published. I mean, this is our review we wrote a couple of years ago. I wrote here as possible because it's still research needs to be done. So increasing incidence of autism spectrum disorders and ADHD or attention deficit hyperactivity disorder. Again, we may be good at picking these disorders up now, but there is a clear link. There seems to be a clear link with high glucose levels during pregnancy for these kids. Right. So hopefully I've given you a summary of what a GDM is, why we need to worry about it, and why it affects both not just the mother as well as the offspring. So I'm going to take you in a slightly different direction to show why we need innovative methodologies, I call it, because it's not necessarily just machine learning and the AI, but there may be other techniques, and why that is important to address some of these. Because what we are not good at is not every mother who developed diabetes in pregnancy will end up having complications. If you leave them untreated, about 15 to 20% of the mothers will deliver big babies. If you have a big baby, there is a high risk of cesarean section, so there is that consequence. And about 5 to 7% of babies who have small babies. So let's say 20%. But we can't yet accurately identify which 20% of these mothers who will have XYZ complications that I just listed. That is where the research needs to happen. That's where I think we need collaborative teamwork to unravel this. So there is also some learnings that we can do from other aspects. I've just said about these complications, but you could ask me, okay, if we identify and treat, can we actually abolish those risks? No, we can't. The current best evidence shows we can only reduce that by about 50%. Again, why? We don't know. It may be ineffective treatment, it may be delayed diagnosis and treatment, it may be some other factor that we don't yet know. So, but our best evidence shows we can only reduce the risk by 50%. Which 50% of women? Again, we don't yet clearly know. And this is one example I will show. This is a complex slide, but I'll take you through it. So this is a very good pediatric academic in London who did this work. So what she asked the question, okay, if we control the glucose levels very well in pregnancy, what happens to the baby's fat content? I just told you, if you leave them untreated, they will accumulate fat, okay? If you treat them effectively, they should not accumulate fat, right? Common sense. That's the question she asked. So what she did is she took two groups of women. One group who had very well controlled diabetes in pregnancy, and another group who didn't have diabetes, very well matched as well as they could match. And then they did 2 MRI scans of the babies. Okay, as soon as, so within 10 days of birth, and about 8 to 12 weeks later, they did a second MRI scan to assess the fat content of the entire baby. And they also ensured all of these babies are exclusively breastfed, meaning that there's no other feed that went onto the baby. What essentially they showed is at the time of birth, even though the difference is not zero, this is the difference in fat content between the very well controlled diabetes group and then non-diabetes group. Even though it's not zero, but it's not statistically significant. So essentially the fat content at the time of the first MRI was the same, okay? What happened to the second MRI? The babies who were born to the mothers with diabetes were very well controlled, only just had breastfed until the second scan. They accumulated fat much more rapidly compared to the control group. So what this tells us is, you could ask me, okay, what happens? The baby is growing fast. What it tells us is something that's happening to the little one. So it's been programmed to retain the fat from exclusive breastfeeding compared to the mothers who had normal glucose levels. So what is the implications? A, we need to predict which babies are going to accumulate this, and B, we need to think about prevention of diabetes rather than diagnosing and treating. Okay, we did Dr. Ram's data. This is, we did the study and looking at about this. We normally, by the way, diagnose diabetes around about 26 to 28 weeks, or sometimes 24 weeks of pregnancy. So these, as a standard scanning, every woman who gets a scan at 20 weeks to detect any congenital abnormalities. So we use that scan. Dr. Suresh devised this, not quite machine learning on this study. It was a manual estimate by 3 radiographers. They estimated the fat content by measuring the thickness of the baby's abdominal wall during that image. We've subsequently done some automated imaging, and we've not yet published it. What this shows is at 20 weeks, a baby whose mother developed diabetes 5 weeks later already have excess fat in their tummy or in their abdominal wall. So this could mean several things. One, that, by the way, these mothers who had normal glucose levels when they entered pregnancy. So this could be the diabetes could have developed even before the 20 weeks, we just not detected it, or it could be it's not to do with the glucose. This could be something else that is going, which we haven't measured. One of the other driver of growth for us is, as I said, fat and amino acids. And it could very well be other things that also is abnormal in these women. Again, we need to understand. So glucose doesn't explain everything. So I said, hold the thought about the baby size and the fat content of the mammalians. And I showed the two babies, the big and small babies. Why is that important? And it is, this is not our study, there's several others published this work. What this study shows is birth weight along the x-axis, and this graph shows the risk of developing gestational diabetes. But this graph, I could change the title to cardiovascular disease, this looks the same. What it shows is if you're born too small and if you're born too big, in this study is these 4 ethnic groups, your risk of diabetes in pregnancy and your own risk of cardiovascular disease high. So too small, too big is a problem. So again, this is not every small baby will develop cardiovascular disease, every big baby will develop cardiovascular disease. We don't know what it is. And this is actually a modeling study from American group, 5 nationally representative studies, which showed, there's 2 graphs, which showed if you're obese at the time of birth, so more than 75th percentile, they classified as obese in this, for the purpose of this study, that irrespective of whatever you're doing, you're going to be obese as adolescent. And they did subsequent studies which shows a projection that this may continue by even up to 30, 35 years of age. And these 3 graphs here is the severity of obesity, and this graph here is if you are born to normal weight. So essentially, if you're obese at the time of birth, irrespective of what you do, you're going to end up obese as a young adult. That's why, as I said, it's too late for us. It's a damage limitation, but these are again data collected at different times, and there is an element of modeling involved to generate this. And there are studies which followed up babies which confirms this. And they did this for essentially developing policy interventions in the States. Again, as I said, smallness and bigness make a difference. You could see some parallels. So there is diabetes in pregnancy, you get small and big babies. There's also ethnic differences. So Indians are one of the smallest babies. By the way, the smallest baby of race is if you're born in Guatemala. So they are the smallest babies in the world. But Far East, Thailand, for example, also babies are small compared to many other races. So if you're born too small, that's also a risk. And there is evidence that there are subtle ethnic differences. We label them as, if for example, take diabetes, for example, even in adulthood, we have a single threshold across the entire world to say if you've got glucose levels above this, you got diabetes. There is no ethnic specific thresholds. However, there are evidence that there may be subtle differences in the threshold at which the risk goes up, not just in adult population, but certainly in diabetes. And this is the data from the UK, which showed that South Asians in this particular population is in and around Bradford. So the big ethnic minority there is Pakistani origin, which shows that at a lower level of glucose compared to white population, they have the same risk. And in this story, the outcome is big baby. So there are possible ethnic differences in the risk factors. These are the traditional risk factors. I won't go through in detail, but every country follows these risk factors. But this is not exhaustive list. This only explain at best about 60% of variation in the complications that we see in pregnancy. And I just showed you by the time of diagnosis, damage might have already been done if you're worried about the child. By the time you get the label of gestational diabetes, then the risk may already been set for the little one. So we do need accurate risk stratification, accurate prediction, and therefore we can work on prevention of gestational diabetes. So we set up a series of studies, and the interest of time, I'm going to quickly show some relevance of what we have showed on PRIDE and STRIDE. PRIDE is the UK study, STRIDE is the India-Kenya study, and trying to identify some novel ways of identifying novel risk factors. PRIDE is looking at common B vitamins, folic acid and vitamin B12. Vitamin B12 deficiency is quite common in vegetarianism, but we also showed that it's very common in Saudi Arabia, for example. So even in meat-eating countries, probably the processing of the meat is making the vitamin availability low in our diet. And STRIDE, and I just showed the risk factors, and Theo gave a fantastic overview of the benefits of Bayesian network analysis and looking at multiple risk factors. Which risk factor causes more weight? We don't, in gestational diabetes, we don't really use composite risk prediction models. We say, if we got one risk factor, we'll test it, we'll treat it, and do whatever we are currently doing, but we don't look at the multiple risk factors, even though those risk factors only explain roughly half of our risk. But even with that, we don't usually use any complex composite risk score. So that's what we try to do with STRIDE, with known risk factors, but develop a complex risk score. We have yet to publish that. Hopefully that will come out soon. So I'll skip these slides in the interest of time. So what we did in PRIDE is we asked the question, does early pregnancy vitamin B12 and folic acid, which two vitamins is essential for our DNA synthesis and repair? Everybody would have heard folic acid and taking folic acid when they are pregnant, but vitamin B12, without B12, folic acid folate can't do the job. So that's why these two vitamins we studied. And what this simple spline graph shows is the relationship is not necessarily a straight line. And this is B12. And you kind of maybe get away with using a straight on relationship like a regression. Whereas if you look at folate, this is a fasting glucose, this is a 2-hour glucose. We measure those two to diagnose diabetes. And you could see this is a curvilinear relationship. So you can't use simple models to predict who's at risk. But what this study showed that if you have low B12 and high folate, low B12 increases your risk of gestational diabetes, low B12 early in pregnancy, and then diabetes in 24 weeks. And same with folic acid. And if you got the two together, the risk just happens to be higher. They don't, we did not prove the hypothesis they are interrelated, but independently they increase their risk of gestational diabetes. So this risk factors, this paper is published. Why is this? This is attracting a lot of attention of folic acid, because women are advised to take folate to avoid neural tube defects, which is a form of congenital anomaly. But neural tube closes at day 27 of conception. The woman taking folic acid after she knows that she is pregnant is already too late. So we're again trying to change guidelines, but it's a long game. So and I'll show a couple of quick slides on other things. This is my fellow who did this work a few years ago, and our colleague. This GLP-1 is a particular hormone, which is GLP-1 analog, is a treatment for type 2 diabetes. And GLP-1 hormone is, if you like, is a midway between glucose and insulin. So you need GLP-1 to produce the right amount of insulin to control the glucose levels. And what we showed is this is also defective in women who develop gestational diabetes. What exactly and how much exactly it does, it still needs to be work done. But what she showed is maybe if we measure the 30 minutes GLP-1 levels, that itself might predict gestational diabetes. You don't need to do the 2-hour test. myself and others have shown that high triglyceride level, which is one of the fat, is a risk factor for GDM. Again, we don't use that for prediction. You may have heard the word, this adiponectin. It is produced by our fat cells. It's a good protein. And if you have low levels of adiponectin, you have higher diabetes risk, higher cardiovascular disease risk. And we also showed that this is associated with higher diabetes risk. Ching, one of my previous Chinese students, shows that diastolic blood pressure in Chinese women is also an independent marker of developing diabetes later in pregnancy. So these are some examples. I'm not giving exhaustive examples. That list is increasing by the day, is trying to identify what are the novel risk factors for gestational diabetes. So in STRIDE study, what we, as I said earlier, we did this in India and Kenya. We want to develop a simple composite risk score that clinicians can use so that instead of testing everyone, if we can improve our predictability of gestational diabetes, at least we can avoid certain testing and so on. So I said 20%, but that means it's still 80% or 70% of women who gets tested who doesn't have gestational diabetes. You may wonder why this testing is so difficult. It's a glucose tolerance test. So you drink 75 grams of glucose, pure glucose, and you have to have, if you follow in certain international guidelines, you have to have 3 tests just before you drink that glucose at 1 hour and 2 hours. In the UK, we only do 0 and 2. So it is a difficult test. Because it is a difficult test, women do not go for the test, and especially in low and middle income countries, at best, only 20% of women ever get tested, if that. In India, we don't have data, but our estimate is less than 20%, even though it's in our national guidelines, etc. So we used HbA1c, which we usually use it for monitoring diabetes treatment. It's a subfraction of our hemoglobin, which goes up if your glucose goes up, and if it goes down, if your glucose go down. So we use that and other simple risk factors such as age, BMI, and family history of diabetes for predicting. So I'll skip these flowcharts. So essentially, we recruited about 3,000 women in India, 4,000 in Kenya. And we use these 3 models, and I think Tav said about, and as well as Rahul said about BICs and AICs, and I've never heard of that before I start doing this. So what we showed is we simply tested these models by simple regression analysis. HbA1c on its own, these are the easily collectible clinical factors. These 2 combined, and then we added some blood pressure with some of our previous work. So what we essentially, so in this paper, which again, about to submit, we used the Kaiki information criteria to look at which model predicts better. So essentially, we showed that if you combine HbA1c on its own is useful, and by the way, lower numbers mean better predictive ability. So we used HbA1c and these 3 risk factors. The combined model did better. And what I won't show you is if we use this model and use a rule in and rule out threshold. So say above this level, you'd certainly have diabetes, and below this, you won't develop diabetes. We could potentially avoid anywhere between 50 and 80% of this glucose tolerance test in pregnancy. It depends on which population. In India, it's about 50%. And in Kenya, we could avoid 80% of GTT, which is a big clinical improvement. So that way we can target a certain group of women to go and have that test. Right, so I'm trying to summarize why I need help with you guys to solve some of these issues. So hopefully I've shown you the adverse disease programming is complex. Everybody looks at genes, but it's not genes. We have 90% homology with chimpanzees. So it's not just genes alone, it's a gene diet and gene environment interaction is what drives that disease progression and programming. So it is complex and we need better understanding. The identification of novel risk factors is developing rapidly, but that is based on prior knowledge, animal studies, etc. There's so many unknown factors we have. And those unknown factors is where I think machine learning can come in. Yes, it can throw the noise, and it's up to then us to put a collective brain and say why that noise is. And we do need better ethnic understanding of the ethnic variations in risk as well as the complications. And the factors that affect mothers. This is what I was trying to ask Tav earlier. The ABC model, and there are certain things that may drive diabetes in the mothers, but not necessarily has all the effects to the offspring is through diabetes or hyperglycemia. And there may be what we do in the clinic, the manipulation of diabetes or control of diabetes, and what does that have an effect on the adverse outcomes, especially if you think of the offspring. We still have a lot of work to do. So again, as a quick win, we can develop composite risk prediction, which may help us personalization. Personalized medicine is a buzzword. It means different things for different people. But when you go to a clinic, is what is the risk for me? Yes, I know the risk in the population, but what is the risk for me? I think we still don't do that well, even in established healthcare systems. And again, this inter and intra-individual variations, glucose changes on a daily basis. There are studies which shows a short-term exposure to stress post 9/11 disaster in the UK has developed neurodevelopmental issues for the offspring at 9, 10, 11 years of age. So we are talking about short window of exposure, leaving permanent damage or permanent risk. So we do, I think, COVID has helped us in this way, hopefully for other diseases too. We are having a better availability of data set, and we need to use that better. So hopefully I've convinced you that we understand human evolution in a very, very superficial and simple way. We need a lot more understanding. And I've showed you that gestational diabetes is an important. And I don't think we need to even ask the question, does it matter? I think we are already seeing the effect, there's possibly a second, third generation effect in our current population. And hopefully I'll also convince you that we do need innovative solutions for these complex issues. So to conclude, as I said, if you want to improve the health of the nation, if I have limited resources, if I become a prime minister of this country, I have no intention, by the way, I will just focus on health of young women before pregnancy. And I may not get the fruit for that 30, 40, 50 years later, but I think we have enough evidence that we can reduce the obesity and cardiovascular disease epidemic. And hopefully you guys can help to develop better and healthier children going forward. These are my funders. Thank you very much, and I hope it was useful.
Fine. So I have few questions from your talk right now. So sir, have you been able to find the exact cause of gestational diabetes mellitus?
That's $1 million question you're asking. So I think reasonable, as I said, we can explain about 50 to 60% of why someone developed diabetes in pregnancy. So we still have a lot to learn of why someone develops diabetes. The biggest risk factor is aging process. While you go back 30, 40 years ago in many countries, avoid teenage pregnancy for whatever reason is a mantra for many countries. But as once a woman passes 21 years of age, I know this is a controversial statement, but there is evidence for this, her diabetes risk goes up. So age is a big risk factor. Then the other biggest risk factor is our body weight, or BMI, body mass index, and then family history of diabetes. And the reason why family history is, I think it is a shared genetics pool, and we know that type 2 diabetes is a polygenic condition, multiple genes contributing to the risk, and same as gestational diabetes. So these, I would say, the 3 biggest risk factors, but there are other risk factors, as I just said, that list is developing rapidly, but we can still only explain about 50 to 60% of the variation. We still need to test many women to diagnose who's actually have diabetes.
Sir, actually, I have one hypothesis here, that is it possible that there are some hormones which are being produced by the baby, and these hormones are interacting with somewhere with some other chemical or the biomolecules of the mother, and this is somewhere leading to those factors which might cause the diabetes?
It is possible, theoretically. There's only one animal study that showed a defect in IGF-1, which is insulin-like growth factor, which is also a growth hormone, if you like, that is transmitted from the father's side, could increase diabetes. There are other conditions in pregnancy, such as preeclampsia, which is a very high blood pressure condition. There is possibly a paternal gene also contributes. So it is possible. And people have worked at looking at male versus female child, because male babies by definition are bigger, that that mother's placenta is bigger, etc. But we still don't clearly know whether that is really true. My gut feeling is, if it is a polygenic condition, yes, that risk may be transmitted by other baby, which is what I think you're asking. But I don't think we have enough evidence to show that that is the case. But it is theoretically possible.
Thank you, sir.
So, I mean, yeah. You talked about different diseases like obesity, diabetes, GDM, and cardiovascular disease. So we know from the studies that gut microbiota, or we can call microbiome, it has been linked with the emergence of diabetes, obesity, or other diseases like NAFLD you talked about. So, I mean, it would be good to fix our gut microbiome, or to have a healthy gut, so that we can prevent these diseases, and also do machine learning on a microbiome data where we can predict before, where we can tell a patient that whether in future they might have these diseases like diabetes, cardiovascular disease, so that they can fix it before time. So they have enough time, like they can have a healthy, how to fix your gut, so that they can prevent all these diseases before. So coupling microbiome and machine learning would be a very good input into all this.
Yeah, I think some of the work has already happened. Very good question and very important topic. When we set up the PRIDE study in 10 years ago, at that time, we did have ethics to collect gut microbiome, both from the mother and the child. We couldn't, because each sample at that time would have cost me £1,000 to do one microbiome analysis. Obviously, the cost has come down. It's not cheap, but it's still anywhere between £300 plus. So multiply that by 100 for rupees. So, you know, the analogy I said, we may all have friends who will eat twice as much as we eat and may stay thin. And one of the reasons could very well be gut microbiome. We know gut microbiome is also programmed. Mothers who have cesarean section, or babies who are born through cesarean section compared to vaginal delivery, they have a different gut microbiome, and they know their metabolic risk is different as they grow up. That technology is rapidly evolving, and I think microbiome data is difficult to do analysis without machine learning. So I think there is a lot, and the only way we solve this is to go towards a personalized medicine approach, because you're not just talking about gut microbiome, but which may also be dependent on your genetic variations. So the two together may give us a lot more answers. Thank you. Any other questions? Great, thank you. I hope you all enjoyed that. And